Hi everyone, it's Dr. David Wilson here, the Doctor and Medical Director at Phoenix International Stem Cell Clinic, and in today's video I want to talk to you briefly about osteoarthritis, sometimes called wear and tear arthritis. I want to talk to you about where it comes from, what it causes, and how we can treat it. We're going to break that down into its different components. We're also going to look at different levels of treatment, so the level of treatment you'd get from a general practitioner or a family doctor. We're then going to look at the type of treatment you get from a physiotherapist and a manual therapy or physical therapy. We're going to talk about the treatments we offer here at our clinic. And finally, we'll have a few words about surgical options. If you haven't seen our earlier videos, some of our introductory videos on this topic, then you are most welcome to go to the link down below. You'll find our YouTube channel, our Facebook page, and there you'll see some of our other videos on this topic and on what we offer in general. If you have any questions at any time, just stick a comment in the field down below and we'll try and answer your questions in a follow-up video, because we like to keep an interaction with our followers, and we want to give our people the answers they desire. When we talk about osteoarthritis, that's often referred to as wear and tear arthritis. Now, that's a bit maybe of an oversimplification, but it's worthy of noting that arthritis in general refers to a joint which is painful, which has lost function, and which really, to put it as simply as possible, doesn't work the way it ought to or the way it used to. There are different causes of arthritis, but in particular of interest to us are the osteoarthritises, and those are the arthritises that are made up of people who've had age-related changes, they've had injuries previously, they've had wear or tear in other reasons or other ways, which have caused the knee joint to start to break down, or the other joints in the body. Now, what's of special interest here then is that when we talk about disease normally as doctors, if we talk about a heart attack, for example, we are describing in particular when the heart is not receiving enough oxygen and some of the tissue starts to die. So that's a very small, narrow definition. In osteoarthritis, actually what's strange about osteoarthritis is that we give the definition and we give the diagnosis based on the loss of function and the pain and the changes people might have on x-rays. But what that doesn't show is that many different pathways can actually lead to the same endpoint or to the same outcome. Now, if we were to briefly mention some of the things that can cause it, well, pretty much every part of the joint that can feel can lead to an arthritis by the end of the day. So, of particular interest then again, if we were to take a joint like the knee joint or a hip, you can have a problem where the bony surfaces, so we have bone coming up and bone coming down from above, and those bones, they meet together, and on the surface of the bone you have a cartilage, a very thin cartilaginous layer, and that's a little bit like a cushion or a spring, or it's like the suspension on a car in a sense. It's there to help bear the load so that you're not just rubbing bone against bone. Well, if you have a problem with that surface, so that can be caused by things like microfractures, so small breaks, small problems. If you have a problem with the menisc, which is actually then a cartilage tissue that's in between the two bones, so that's what you will hear people talk about when they've injured themselves, often in sports injuries, they get meniscal injuries or tears. If you have a problem with the menisc, you can have problems in the joint that later become arthritis. If you have problems with the joint capsule, where you have a constant inflammation or irritation, if you've had capsule tears, so a capsulitis or a synovitis, those can also lead to arthritis later down the line. Finally, you can have changes that are outside the joint space itself, but which still affect the joint itself, and those would be things like if you've muscle problems right in the area there, or tendinitises, or maybe you've been in a cast for a longer time, and sometimes that can happen as well. As people use the joint less because of other disease, it actually increases the speed of onset, and it makes people get their arthritis earlier than they otherwise would have. So if we were to take that as kind of a brief outline of where arthritis can come from, and like I say, arthritis itself is then where you have a painful, often swollen but not always, and loss of function in the joint. So the joint no longer either flexes fully or can't extend fully, or you have lost some of your movement because of the problem you have there. We end up then taking x-rays often, and an x-ray will often show arthritic changes. That's classical x-ray findings. That being the case, we can make the diagnosis. And like I say, the diagnosis then is kind of the end point. By the time you've got to the diagnosis, you've already worn the joint somewhat. And that brings us then to the first question is, well, what do we do with these patients? Now, if we have a mild or early onset case, we often try to find out the underlying cause and treat that as best we can. So we will begin by asking the patient for their history and background. We'll try and go through any traumas or injuries they've had. We'll talk about what kind of work they have, and we'll try and summarise those things into the journal. Then, having looked at that and considered where the patient's coming from, we try and decide the best first course of action. In almost all cases, the best first primary action for a doctor to take is to recommend that the patient should train more. If they're overweight, they should try to lose weight. And finally, give them pain relief. Now, pain relief can be a slightly more complex issue because depending on underlying other illnesses like diabetes or heart problems, there may be a limit on which medications we recommend. But as a general rule, we recommend to people paracetamol. It's usually a safe choice unless you have a liver disease. After paracetamol, the next level is usually anti-inflammatory medicines like ibuprofen, diclofenac. Here in Norway, they call those Ibux and Voltaren, but you don't have to buy that specific brand. As long as it contains a non-steroidal anti-inflammatory, that will cover your needs. If that's not enough, then people need to be considered for opioid treatment. Now, this is something I'm personally skeptical to, and actually, in general, doctors try and keep patients away from the opioids because they are addictive and they can cause problems down the line, not least with side effects. But having said that, we've also skipped over the side effects and the negative consequences of taking anti-inflammatory medicines, and they also have a price to pay. There is relatively new research which suggests that anti-inflammatory drugs actually increase the risk, the lifetime risk for people of having heart attacks or cardiovascular problems and of having kidney problems. And not only that, it's a well-established fact that anti-inflammatory drugs actually increase the risk of gastric bleeding or gastrointestinal bleeding. So people who've been taking anti-inflammatory drugs for more than 4 to 6 weeks are definitely at an increased risk there. On the other hand, training is rarely dangerous or rarely bad for your health unless you have a very established and advanced disease for some other reason. Obviously, if you have an underlying disease or sickness, talk to your doctor and have them go through your health with you and find out what you should do, because obviously every type of training is not for every person. Assuming then that you've been to your doctor, you've received some good guidance, you've started training, maybe you've lost some weight, the other good advice just in general for lifestyle would be to stop smoking if you're a smoker and to keep your alcohol intake moderate. Moderate intake of alcohol and cutting out smoking are probably the two best choices a person can take for themselves in terms of their long-term risk for sickness and disease. We know, in fact, that if you smoke, it decreases your ability to heal from illness. In particular, it actually decreases your ability to have good circulation to the area of the body that's injured. So we definitely see a huge difference in people, for example, after they've broken a bone, in how long the recovery takes and in how often they have complications. Moving on then from training and sort of the so-called conservative treatments, we can step forward and talk about, well, other treatments that are available. Now, here at our clinic in Lillesand, we offer people a regenerative treatment. That is to say, we use the body's own stem cells to help the body heal itself. In particular, when we talk about arthritis, we take mesenchymal stem cells. These are the stem cells found in fatty tissue. You also find them in bone marrow, and to a very minimal degree, you may find them in circulating blood. The difference between those is really an exponential factor. You have maybe a few dozen circulating mesenchymal stem cells per milliliter of blood. You have a few thousand, so the research suggests between 1 and 10,000 milliliters, 1 and 10,000 stem cells per milliliter of bone marrow aspirate. And in fatty tissue, you have about 1 million mesenchymal stem cells per milliliter of tissue aspirated. This is showing, therefore, the extreme power that you can have in terms of treatment and regenerative ability from an adipose stem cell aspirate. What we do is we bring the patients in and we settle them down and wash, sterilise the area, and then we actually harvest about 15 to 20 millilitres of tissue, which is then centrifuged down into its component parts, and of that product we actually only remove the stem cells. Those cells are then mechanically stimulated, just back to forward in syringes, and largely because in the European Union and indeed the European Economic Area, which is where we're part of, it would be illegal to do any other treatment. We can only minimally manipulate those. We're not allowed to add anything to the treatment. So that being done, we end up with a lovely product that's got millions of stem cells, which we then can inject into a degenerated joint. And we do that, then we follow that up with some chiropractic manipulation just to help open the joint up, and then we give a laser treatment. We have a laser machine here that we use to stimulate growth and repair in tissues, because there is some research which says that if you use laser on cells, you actually give the mitochondria a boost in energy production. And for these cells that we've removed, well, we've taken them from their natural fatty habitat and we've set them into a joint that is degenerated. It is of immense benefit for these cells then to be given a boost just on day one. That actually helps those cells to grow into the surrounding tissue and to give a better result. We then follow up with 2 rounds of PRP. Now, PRP is a shorthand or an abbreviation of platelet-rich plasma, and that's a blood-based treatment.